reconstructions. So I thought I will present a different case, that is ACL tear in a pediatric age group. So here is a 11-year-old boy who had a history of fall while playing football 2 months back. He took some rest, he is all right, he is doing his normal activities, and again he wanted to play. Again he had a history of fall 2 months later. At that time he presented to me. On he has a history of instability, and on clinical examination, Latchman test was positive, anterior drawer test was positive. Range of motion was 0 to 100 degrees, and this is his X-ray. And on MRI, there is a complete tear of ACL. There are no other injuries like meniscal tears or chondral injuries. So, how do you proceed, sir? Mukesh, sir?
Is he complaining of instability, frequent fall?
Yes, this is the second time he had fall while playing football.
So I'll definitely go for surgical management because MRI is showing complete ACL tear, and also on your clinical examination and history wise, so it's not going to heal without surgical intervention. He is 11-year-old only,
11
so
years.
I'll do total transfacial ACL reconstruction with outside in femoral.
That part will come later, sir. Any other opinion, any other conservative treatment opinion from the
Anyone
panel?
conservative? Sandeep?
Sandeep.
He is busy. He had not seen the game. He's an 11-year-old boy with complete ACL tear, complaint of instability, clinically and MRI wise, this complete ACL tear. 11-year-old boy. So will you do conservative or you will go for surgical?
Latchman is positive, anterior drawer positive, range of motion 0 to 100 degrees. And no other pathology like meniscal tears or chondral injuries, nothing.
Is unstable.
It is unstable.
Then I think it's a surgical only.
11
No
year.
role of conservative.
Yeah. No
Anyone
role
from
of,
audience will conserve this?
anybody wants to conserve this patient? 11 years old boy.
Okay.
So I hope everyone agrees for the surgical management. So when to do surgery? Immediate or delayed after fascial closure?
I'll not wait. For fascial closure, you'll have to wait for another 5-6 years. He's 11 years. The secondary growth spurt has just started. It's not been completed. Then there are various scoring systems which you do to assess the amount of growth remaining. If he would have been, say, 13 years plus, I would have done a transfacial also. But now he's 11 years, the physes are yet open, and being a boy, the secondary growth spurt is just about to begin. So here I won't do any delayed reconstruction, I'll do right now, but all fascial sparing.
Sandeep, sir?
Immediate surgery.
So what is the problem if we delay, sir?
Being unstable, 2 times he had fallen in 2 months, he will break the meniscus, he'll get some cartilage injury.
So that is the reason we should do immediate surgery in this patient, because if we delay for the fascial closure, meantime he will have repeated falls and he will have other ligament pathology or meniscal pathology or chondral lesions. So what technique you want to follow? There are 3 techniques. Fascial sparing, that is all epifascial, the first picture. Second is partial transfascial, that is femoral side it is epifascial, and on the tibial side transfascial, and complete transfascial, the third picture. Which technique do you want to follow in this patient of 11 years old boy?
Sandeep?
Sandeep?
For the femur, fascial sparing, and for tibia, means like I'll be going for the suspensory fixation, so I won't be hesitating to do transfascial.
Transfascial. Your
Total,
take, sir?
I'll do complete fascial sparing.
Okay. Any criteria do you follow for selecting these procedures, sir? Any criteria do you follow, like age or
I was saying
physis?
age, secondary growth spurts, I think it's a Tagnard scoring or something which you have to do and see how much amount of growth is remaining. But being 11-year-old boy, the secondary growth spurt has just started. So another 2 years he will have a significant growth phase. So I don't want to damage any physis neither on tibia nor on femur. So I'll prefer both fascial sparing ACL reconstruction.
Any difference of opinion, sir? Mike.
think both are good options. One, because complete sparing of this physis, epiphyseal is great. With CM guidance, we can do it. And what Sandeep also mentioned, because we have to go according to the Tanner stage. And only thing is, we have to keep the principles of when we're using the physis. 11 years, we can still do it, but certain principles of when we are going through the physis, we have to keep certain principles. The only thing we have to remember. That's what I feel.
That means oblique tunnel versus vertical tunnel.
Right.
Yeah.
And the other, I think the panel can discuss, I think it should be a more vertical tunnel, because more oblique the tunnel is, the more of the growth plate goes. Yeah. And what Sandeep was saying is very valid, because he's planning to do a suspensory fixation both sides. So that's a very critical point, because you don't want any kind of metal or any kind of hardware in the physeal area.
Yes.
So that is another important thing. And another, I would say that there is a very important paper regarding the graft size. What is the size of the graft? Yeah. I think the panel can elaborate more on the graft size.
So we have to decide depending upon the Tanner staging, whether it is stage 1, stage 2, stage 3, 4 or stage 5. And we have to take bone age into consideration, not the physiological age, bone age. For that we have to take X-ray of the hand to determine the bone age. Depending upon the bone age and Tanner staging, we can decide the treatment in this aspect. So here, this is the algorithm we will follow usually. For a complete ACL tear in a prepubescent, that is less than 12 years, if that Tanner stage is 1 or 2, we can give a trial of non-surgical treatment, activity modification, functional bracing. And if there is recurrent instability, then in that age group, fascial sparing is the ideal. All epiphyseal, that is all inside, hamstring autograft. If he is an young adolescent, that is growth remaining, Tanner stage 3 or 4, and 13 to 15 or 16 years age, then we can consider partial transfascial, that is on the femoral side, all epiphyseal, and on the tibial side, through the transphysis. And older adolescents, Tanner stage 5, or more than 15 years, then we can do adult ACL reconstruction, like in adults, without considering the physis. So what graft do you want to prefer in this case, sir? Soft tissue or BTB?
No doubt, soft tissue. BTB you can't have, his physis are still open.
So no bony grafts in this age group, only soft tissue graft, either hamstring or peroneus. So what is the fixation method you want to follow, sir, on the femoral side and on the tibial side?
So first of all, the tunnel will be very horizontal on the femoral side.
Femoral side.
It will be a horizontal tunnel outside in technique.
Outside.
You have to be parallel to your femoral physis. And tibial side, you have small tunnels. So the graft will be hamstring, only semi-T, maybe double bundle only. I don't want diameter more than between 6 to 7 mm diameter only. And on the femoral side, I'll prefer to use endo button direct, because I want my whole graft to be in the tunnel, because the tunnel length is too small. You can't use your any suspensory fixations like endo button, CL or any adjustable loop. So I'll loop it over endo button direct, and on the tibial side, I'll tie it on the suture disc or anything like that.
Any other fixation method?
No, so for me, femur side is adjustable button, all inside with the flip cutter. Tibia is through and through over the jig. Okay. Graft either semi-T or CQT, and femoral tibial fixation with suture disc.
Suture disc. Any other difference, sir, from the panel? Okay. So what is the rehab you want to follow, sir, after the fixation?
What you did first.
I'll show you.
Then we go for rehab.
Okay. So this is the position and this is the diagnostic scopy. He has complete tear of ACL. So femoral tunnel outside in with flip cutter. And on the tibial side through the CM image. This is also fascial sparing, all epiphyseal. So we need to use the CM in doing the tunnels for pediatric ACL, because we have to avoid the physis. And this is the quadrupled semi-T graft. And on the tibial side, I have pulled it and tied it to the suture post below the epiphysis.
Very well done, sir.
Yeah, this one. This is after 3 months, he has complete flexion and complete extension. And this one after 1 year. Just yesterday's video, I asked him to send a video. And this is after 1 year.
Excellent results.
What was the diameter of the graft?
Sir,
What was the diameter of the graft?
diameter was 7 mm, sir. That is quadruped semi-T only. Thank you, sir.
Nice.
Thank you very much.
Can we to Rajiv da? Can we connect to OT?